Good morning, everyone. This is the plenary session dedicated to the presidential lectures. And you know, the presidential lectures are a nice opportunity to recognize people that have contributed so much to the society. And there are two awards, the Stanley Fahn for clinical and the David Marsden for basic science. It is a great pleasure now to introduce the first speaker. Ali Rashput has been a beacon of light in the field of movement disorders, located in the remote city of Saskatoon in Saskatchewan in Canada. And I think it's more than proper to recognize him here in his own country. Ali has been like a jack of all trades. He's a clinician who has done everything. So we can learn a lot from Ali Rashput. So I would welcome Ali to the podium. He will deliver a lecture, The Saskatchewan Way. So you can advance from here. Okay? You have slides. Okay.
Thank you very much for this honor. It's really a great pleasure to be giving a lecture in the name of Stanley Fahn, whom most of you know. His pictures are coming. Okay.
It is.
Oh, it's there. Okay. Stanley Fahn is a Houston Merit Professor of Neurology at Columbia University, which is one of the major American universities. Everybody knows about that. Now, I just want to go over some of the historical aspects and what professors do. What do professors of neurology do? Well, they provide patient care. Of course, they teach undergraduates, postgraduate, research, basic, clinical, leadership, local, national, international. But Stan Fahn has done every one of those, and he's done it very well. So he's the founder of this society, so he is an exceptional individual who has done it all. And to boot it all, he's one of the nicest guys that you want to meet. Stan, I'm not sure if he's here or not. Stan, thank you for doing what you've done. And thank you for being who you are. Thank you. The objective of this lecture is simple. I'm going to show you that a small-sized city, which we are, it can produce some reasonably good research, and to share with you some of the examples how we have advanced the knowledge of movement disorder. I have no conflict of interest. I'll be wandering around from one topic to the other, not one topic, but it is what we have done in Saskatoon. So it'll be a diverse topic. I'll introduce why we did something and what we found and how it has advanced the knowledge. Well, this is Saskatoon. Where the hell is Saskatoon? Well, a friend whose name is Richard Ferry, who and I trained in Ann Arbor, he sent me this bumper sticker in September 1984. Richard was not very happy. We were trying to relocate their NHL team to Saskatoon. So this was their bumper sticker, that they didn't like us. Well, we didn't succeed, so we are still friends, you know. But anyway, some of you have asked, where is Saskatoon? So I'm going to show you where Saskatoon is. Oh, you are here in, what is this pointer there? Is there a pointer here somewhere?
I think there are 2 screens.
Okay. Well, you are here in Vancouver, and we are northeast of Vancouver, about 1,200 kilometers. For those of you who count in miles, it's 750 miles. It's a very large place. It is really on the map. It's there. It exists. My PSG group thought it didn't exist, but some of you have visited, so it is there. And Saskatchewan is a province. It's size of Texas or twice the size of Italy, and the population is just over 1 million, so it's a very thinly populated place. I'm going to talk about advances, movement disorders, how we move the needle. It's a slow way, so I'll go over that slowly. It's an agriculture province. You see that wheat pool, it's gone now, things have changed, but that's what it is. It's an agricultural province, a very large province. Well, my office is in this building, and it's really the corner office, but I don't have the clout to go with it or the money to go with that, you know. It's just a corner office. It's at the main level of the hospital. Well, I came to Saskatoon exactly 50 years ago, 1967, for 1 year, and then I committed to 1 more year. It's still going on. It's been a long year. I was a salary professor, so really I had to work accordingly. Canada has a universal health care system, as you know, but it started in Saskatchewan. Saskatchewan is the founding place of health care in Canada. In 1962, it began in Saskatchewan. I could see as many patients as I wanted to, or as few as I wanted to, and as often as I wanted to, and spend as much time as I wanted to. So I had that freedom. I had low salary, but that's all right, you know, I could live on it. But I had no money, there was no manpower, there were no mentor, there was no special machines, and there was no protected time for research. So you can see the situation was a bit different. I realized that I could not compete or even copy the larger, faster, and wealthier programs, so I needed a special approach to research if I wanted to do research. My strategy was very simple. I decided that I'll do what I can do and do it well. And for credible research, I realized that I need expert collaborators. I couldn't do it alone. By now, we have more than 25 expert teams collaborating with us, and I'm very proud of them. I'll mention some of those to you. And I wanted to be patient because I couldn't hurry anyway. This is how the Saskatchewan Movement Disorders Program works. Patients are referred by the family physicians, most of them. We do the general neurological examination, motor UPDRS, Hoehn-Yahr scale, activities daily living, mini-mental scale, mode of onset, treatment effect. We all do that, and we do the video on all the consenting patients. Alex joined in 2000. I have been there since '67. We follow our patients every 6 to 12 months, and similar assessments are done every time we see the patients. Then we ask them to have the declaration of desire for autopsy. Those who say yes, then we give copies of that to the patients and families. The usual course of our research is, of course, the arrow on the left side shows. It is from there, those patients who are deceased, we do an autopsy, which is about 1/3 of the patients. 1/2 of brain is put in formalin, and the other half is frozen at -80 degrees for the further studies, and I'll show you some of those. Rarely we go in the reverse direction, that we have found something in the brains, and then we go back and look at the clinical part of it. What did we have clinically there? 2 of us right now, Alex and I, we are on 24/7 call for autopsy and freezers, and it's unpaid call. They don't get paid, we don't get paid for that. This is a summary of the program. You see on the A, it is the clinical records. The hard copies are kept there in our special lab. Then B, you see the freezers. There are 9 freezers, the commercial size freezers, -80 degrees. C, you see every half brain is frozen in a special box with a number assigned to that, and that's kept there. And D, you see the remnants of the formalin-fixed brains that are handed over to us by pathology. We keep those. And You see the paraffin blocks and slides they give us back, so we keep those. And then if you have the videos that we kept all once, then we will transfer them to the digital one. So far, we have about 6,000 videos on our patients. To date, 549 autopsies have been performed on our own patients. It's not a bank. It's not a bank. We do not accept brains from patients that we have not seen. If by accident they have come there, we will not use them for our research. It's more, I can't find a better term than say it's a safety deposit, not a bank. We published an article, a review article back in 2015 in the Canadian Journal of Movement Disorders, and it is open access. Anybody can access that. The setup is such that it allows us to do several things that I'll show you some of those. So it's going to be a wide-ranging things, not one topic, but different things that we have done, and I explain to you why we did it and what we found very quickly. I go over that. Now, there's no laboratory test for ET diagnosis. When I was going through training, I was taught that if the tremor improved with alcohol ingestion, it's essential tremor. Well, I tried to find out where it come from, but couldn't find any literature. So I decided to do the study myself, and these are occupational therapists working with me. We studied 39 cases, 62% of the essential tremor, and 47 of the Parkinson's disease patients' tremor improved with alcohol. Even a patient with ataxia telangiectasia and a C7 spine injury improved with alcohol. So it's not specific. I don't think anybody is teaching that's specific for diagnosis anymore. Well, the optimal dose of levodopa was not established before its widespread use. It was just a storm came and everybody was using levodopa. Like many others, I observed that there were many side effects from that, notably dyskinesia. So on the large dose, so I started using lower dose, 600 milligrams equivalent of cinnamon, and we published that in 1984 in Neurology, Chronic Low-Dose Levodopa Therapy, and it was a 12-year study of 194 patients. Patients did well and had fewer side effects. In 2013, Warren Olano and group reported similar observations. So it's now a fact that we know that larger dose does produce more side effects, and people tend to go on a lower dose as necessary. Now, levodopa is the most effective symptomatic drug, but the effect on life expectancy could not be determined because we don't have the controls. So we did this study, reported in 1997. Underlined is my Mayo Clinic colleagues who have been very kind to me. And we said timely levodopa administration prolongs survival in Parkinson's disease. This was a study of 934 patients over 22 years. Levodopa, covering the era that there was a limited access to levodopa to where the levodopa was readily accessible. And we discovered that after levodopa became widely available, survival improved. Most neurologists believe that, like I did, that when we diagnose a patient clinically as Parkinson's disease, that's a Lewy body disease. Well, when I started doing autopsies, I was surprised that I was wrong. It was deflating the ego, but that's the fact what it was. So we published that in 1991. 76% of the cases we were right, but in 24% we were wrong. A year later, Hughes et al. From London reported identical report, 76% error rate. Now it is a fact of life that whenever we do studies, we factor that in, that there's going to be a clinical diagnosis errors. Another issue was that on tissue cultures, animal studies, it was thought that levodopa was toxic to substantia nigra. Well, when I was autopsying these patients, I had patients that had long duration levodopa, but their substantia nigra was normal. So we reported that to 5 patients with 2 autopsies that it was not toxic. Well, we followed it up with a more recent paper of 21 autopsy cases where the substantia nigra was normal and they had long duration of levodopa therapy. So it's not toxic. You can use it as you see fit. Levodopa is a highly effective drug in most, but not all Parkinson's disease cases. And we reported this back in 1990, a pathological study of 59 patients with 22 years duration. All Parkinson's disease patients that tolerated the drug improved. And even 33% of the multiple system atrophy patients improved on levodopa. So it's not a diagnostic test that you can use that because it improves, therefore it's Parkinson's disease. Other conditions also improve. Now, Parkinson's disease phenomenology is such that you have resting tremor, bradykinesia, and rigidity. But the essential tremor patients have only action tremor. So significance of Parkinson's manifestation in essential tremor, this is a paper that we published in 1993. There's an autopsy of 9 cases. 1/3 of the patients had essential tremor plus resting tremor, but no bradykinesia and rigidity. So we said this is part of the spectrum of essential tremor. And we recommended that second diagnosis of Parkinson's disease should only be made when all 3 of those resting tremor, bradykinesia, and rigidity are present in essential tremor patient if you're making second diagnosis. Essential tremor was known once as benign essential tremor. We don't use the term benign anymore. But the entire course of the disease was not known. This is a study of 20 cases that we reported in 2004, 31-year follow-up. With time, the tremor involved more and more anatomical sites, and it became more pronounced. So that is, and some of them develop resting tremor, as I noted before. There are many cases of drug-induced Parkinsonism that you know, but there are very few autopsies to show what is happening in the brain in these patients. This is a study that we reported last year, 7 autopsies cases. When the Parkinsonism was due to the drugs only, there was no pathological change, no histological change. There may be some changes that we still have to work on. Now, elderly population is increasing, and I can sympathize with that. I'm in that category. So it's increasing more rapidly than the general population in North America. And the incidence of Parkinsonism increases precipitously after age 80 years. But what type of Parkinsonism do they have is not known. So we did this study in octogenarian Parkinsonism, clinical pathological study, reported earlier this year. We identified 30 patients from our clinic that had onset of Parkinsonism after age 80, 80 over. 70% of them had Lewy body Parkinson's disease. All Parkinson's disease patients improved on levodopa. There were no MSA cases and no corticobasal degeneration. There were PSP cases. So we recommend that anybody who sees a patient who is older, do not hesitate to try them on the treatment with levodopa. You might improve their quality of life. Well, I understand there has been a debate here that Parkinsonism can be transmitted from one individual to the other. I wasn't involved in that debate, but I have heard that. So we looked at conjugal Parkinsonism, a clinical pathological study. And here we have now Dr. Farrer, Matt Farrer, who is a geneticist, right, in this fair city. And he and his team joined us. So what we did was, we had a number of patients where there were couples who had Parkinsonism. but we restricted and for this study only those patients where we had both members of the couple autopsied and both had genetic studies. So this is 10 people who all had all the studies done, and we reported on that. And in these cases, we found that neither Parkinson's disease, nor MSA, nor PSP were transmitted from one spouse to the other. So you can rest assured it's not transmitted from one spouse to the other. The pathogenesis of Parkinson's disease remains unknown. And this is a study by my friend and colleague, Dr. Honikevich, who most of you know about. It's primarily done in the center, and you can also see the name Obeso here. And this is a study of 6 Parkinson's disease patients, 4 controls, and MPTP monkeys, which Jose Obeso provided the material. And on the basis of that, Honikevich group concluded the primary site of pathology is the defective vesicular storage, vesicular dopamine storage. MPTP monkey did not show the same thing. So they made a distinction that MPTP is a good model, but it's not exactly the model that we have for naturally occurring Parkinson's disease. This is another collaboration of ours from Quebec City, Trace DePaulo and Frederic Collin, and they've been working on essential tremor. Now, there is no consistent histopathology in essential tremor, but is there a biochemical basis? So this is a study of defective dentate nucleus GABA receptors in essential tremor. A study of 10 patients, ET, 10 PD, and 16 normal controls. And there was reduced GABA-A and GABA-B receptors in ET patients in the dentate nucleus in the Parkinson's disease patients, but not in the others. This needs to be repeated by other people to confirm. We are still working on that further. Now, clinicians know that there's some patients with Parkinson's disease, they have more tremor. There's some who are more akinetic rigid. Why is it happening? So this is a study, again, with Honikevich's help, in which we looked at the globus pallidus. We looked at all the areas of the striatum and pallidum, but it was globus pallidus that was the main focus. And you see here on the left side the akinetic rigid Parkinsonism, and on the right side you see the tremor dominant. So the loss of dopamine is the greatest in the globus pallidus, internus, in the akinetic rigid, and the least in the tremor dominant. So they're two different, and you can see the mixed variety in between there. So the 3 are different biochemically. Well, what is the clinical significance of that finding? Well, we reported a 39-year clinical pathological study in 2009 where we reported 166 autopsy cases. Akinetic rigid patients had more rapid progression. They had a shorter survival. There were fewer who improved on levodopa, and their dementia was more common. Wearing off was more common, and of course people who improved, those who didn't improve, they wouldn't have any wearing off. So their response to levodopa and the overall prognosis is worse in akinetic rigid than in tremor dominant. Now remember, these are autopsy verified patients. We are not talking about different diseases. It's the same disease that we're talking about, histologically the same disease. Now what does that mean? Can we tell ahead of time who's going to develop into this kind of clinical picture? Well, we have a paper, but it's under embargo. I can't tell you about that thing, but it's coming out very soon. So we have the information on that. Now this is Matt Farrell's group, and I'm very proud of them. They're very kind to provide the support for genetics. And you see Dr. Criswell and Dr. Stossel, they are very kind again to give us the help. PET scanning, which we don't have. We are a poor province, so I depend on a lot of people around the world to help us. So this is a study of large Saskatchewan family, DNA GSC13 mutation in Parkinson's disease, and there are a number of other studies that they're doing together. So it's another part of a big team, and I'm very happy that they're there to help us. I'm going to stop here. Thank you very much for your attention. I have gone over a lot of little things, but I thought I'll cover what we do. And if there are any questions, I'll be happy to answer.